Acne vulgaris is a common inflammatory skin condition that primarily affects adolescents and young adults, though it can persist or even begin in adulthood. It's characterized by the presence of comedones, papules, pustules, and in more severe cases, nodules and cysts. The primary areas affected are typically the face, chest, and the back, where sebaceous glands are most abundant. The pathogenesis of acne is multifactorial. Key factors include increased sebum production, often triggered by hormonal changes, molecular hyperkeratinization, colonization by Cutibacterium acnes, formerly called as Propionibacterium acnes, and subsequent inflammation. It's important to note the role of genetics in acne susceptibility. Additionally, certain medications, including those containing corticosteroids, androgens, or lithium, can exacerbate or induce acne. When it comes to management, we typically employ a stepwise approach based on acne severity. For mild acne, topical treatments such as benzoyl peroxide, retinoids, or a combination of both are often sufficient. In moderate cases, we may add topical or oral antibiotics, with tetracyclines being the first line choice. For severe or resistant cases, oral isotretinoin is highly effective but requires careful monitoring due to the potential side effects. In female patients, hormonal therapies such as combined oral contraceptives or spironolactone can be beneficial, especially for hormonal acne. It's crucial to educate patients about the chronic nature of acne and the importance of adherence to treatment regimens. Results are often not immediate, and it may take several weeks to see significant improvement. Lastly, while the link between diet and acne remains controversial, recent evidence suggests that a low glycemic diet may have some benefit. However, more research is needed in this area. So remember, for the exam purposes, acne can have significant psychological impacts on patients. Addressing these concerns and providing support should be an integral part of acne. Atopic dermatitis is a chronic inflammatory skin condition characterized by intense pruritus and eczematous lesions. It typically presents as a scaly erythematous rash with a predisposition for flexural areas in older children and adults, while infants often experience involvement of the face, scalp, and extensor surfaces. The condition is strongly associated with a personal or family history of atopy, including asthma and allergic rhinitis, and can be exacerbated by various environmental factors such as irritants, allergens, and stress. In the differential diagnosis, it's important to consider conditions that may mimic atopic dermatitis, such as granular parakeratosis, which can present with similar clinical features. Management of atopic dermatitis involves a multifaceted approach, including regular use of emollients to maintain skin barrier function, a judicious application of topical corticosteroids for flare management, identification and avoidance of triggers, and antihistamines for itch relief. Patient education regarding proper skin care and the chronic nature of the condition is crucial for long term management. In severe or refractory cases, additional therapies such as topical calcineurin inhibitors, phototherapy, or systemic immunosuppressants may be considered. Contact dermatitis is an inflammatory skin condition characterized by a red pruritic rash that develops following direct exposure to irritants or allergens. It can be classified into two main types: irritant contact dermatitis, which is more common and results from direct skin damage by irritants, and allergic contact dermatitis, which is a delayed hypersensitivity reaction mediated by T lymphocytes. Common triggers include nickel, fragrances, plants, example poison ivy, and various occupational exposures. The rash typically appears within hours to days after contact with the offending substance and is often localized to the area of exposure that it can though it can spread beyond the initial site. Management of contact dermatitis primarily involves identifying and avoiding the causative agent. Patch testing may be necessary to pinpoint specific allergens in cases of allergic contact dermatitis. Treatment typically includes topical corticosteroids with the potency selected based on the severity and location of the rash. For more extensive or severe cases, short courses of systemic corticosteroids may be required. Oral antihistamines can help alleviate pruritus, though their efficacy in contact dermatitis is limited. Patient education regarding proper skincare, including the use of emollients and barrier creams, is crucial for prevention and management. In occupational settings, protective measures such as appropriate gloves and clothing should be implemented to minimize exposure to potential irritants or allergens. Psoriasis is a chronic immune mediated inflammatory skin disorder characterized by well demarcated erythematous plaques with silvery scales, typically affecting the extensor surfaces, scalp, and nails. It results from accelerated keratinocyte proliferation and aberrant differentiation, driven by a complex interplay of genetic and environmental factors. While the exact etiology remains unclear, a strong genetic predisposition has been established with several susceptibility loci identified. Common triggers include stress, infections, particularly streptococcal, certain medications, example beta blockers, lithium, and trauma to the skin. It's called Koebner phenomenon. Management of psoriasis follows a stepwise approach based on disease severity and extent. For mild to moderate cases, topical treatments form the cornerstone of therapy, including corticosteroids, vitamin D analogs, example calcipotriol, retinoids, and keratolytics. Phototherapy, particularly narrowband UVB, is an effective option for more extensive disease. In moderate to severe cases, or those refractory to topical treatments, systemic therapies may be necessary. These include traditional immunosuppressants like methotrexate and cyclosporin, as well as newer biological agents targeting specific inflammatory pathways. Example TNF alpha, interleukin 17, interleukin 23 inhibitors. Patient education regarding the chronic nature of psoriasis, potential comorbidities, and the importance of adherence to treatment is crucial for optimal management.